Without wasting any time, we're going to move on to our next segment. In this segment, watch our industry experts discuss about the environmental disasters and their better risk management. I would now like to please request our session moderator, Miss Lynn Johnson, to take the stage.
Okay, and here come my fellow panelists. We have Minda Wilson, Kelly Christina, Scott Dodson, and Ian Slade. So if you'd like to come on up. So thank you for all of you that have stuck in for the rest of the day here. We're excited to see you all. I'm going to have everybody introduce themselves. Thank you for the introduction. As was stated, I'm Dr. Lynn Johnson. I'm the president of Opus North America. So I'm going to allow my fellow panelists, who are going to be your esteemed discussion panel, to introduce themselves. Yeah, I think there's one for everybody.
Hi, I'm Kelly Christina. I'm the owner of KD Staffing, and so we staff hospitals nationwide. On the side, I do a lot with the government. I guess you could call me a medical lobbyist.
Hi, I'm Scott Dodson. I'm the co-founder and managing partner for a group called Holson Consulting. My partner and I have a little over 60 years of experience in the medical device industry, working for blue chip companies, leading mid-caps, and also starting or working with venture capital companies from inception through IPOs and other exits. So our focus and our business is working with companies in the venture-backed and the mid-cap space, launch products into global markets. We have over 80 products between my partner and I that we've put into markets, and helping groups work with areas such as market sizing, segmentation, uptake, reimbursement, the whole ball. So great to be here. Thank you.
Hello, Ian Slade, managing partner, IT Consulting Group. Help companies who are looking into getting into healthcare. And on the side, I teach grad school at UCLA.
I'm Minda Wilson, founder of Fluidity Health. We have a care coordination, communication facilitation platform that helps people manage the care for their loved ones.
Perfect. So the first question that we're going to put out to the panel for discussion is, what changes can we advocate for to help providers positively impact their bottom lines, thereby enabling them to reduce the cost of care?
I guess I'll go first. You know, running a company, budgets, you know, we all have to make our money. Everybody's got to get paid. But I truly believe, especially with the medical industry and all the changes that have gone through, I personally work with a lot of the hospitals, and they are losing a lot of money, to put it very nicely. And so I've tried to change my approach, and I think if you're going to try to make a difference, then you have to sometimes change your approach from it's all about money to it's all about how can we help each other out. Make our money, soften the cost. About 5 years ago, I kind of changed my strategy and my thinking with my own company. And so knowing that the budgets are not where they used to be, or can they afford what we used to on outside staffing. I came from the travel segment that charges hospitals, medical, short-term contracts, charging about 4 times the amount to the hospitals that my company is going to do itself. I have a smaller fee. I make a lot of price exceptions. I do not charge my medical professionals or my hospitals, so I feel like when they use my company, it's a win-win. It helps their budget, and it helps me, and at the end of the day, if you're a little bit better with your employees, you set them up for success.
I think one of the most interesting things for me is the elephant in the room, which is insurance reimbursement. One of the studies that I read recently was done by the CDC, and what they determined was less than 10% of every premium dollar is actually paid back into the system for healthcare services. So that means that we, as providers in the system, have to work together to make sure that we get a larger part of the reimbursement pie from the insurance companies. And I think when you're looking for collective action, that's something we can work on. We can work for regulations to ensure that when people pay premiums for health care, they're actually receiving health care services.
For me, I come at it from a different angle. I teach enterprise project management, execution on a health system level. And if you look at projects in healthcare, 70% of them either don't come in on time, they're over budget, and if you sum that up, we're talking hundreds of billions of dollars, not millions. And a lot of that waste comes to learning how to execute, properly plan, and also tie in what you're doing now to the business case, and also looking at, will this still make sense 1, 3, 5 years down the road? And you'd be surprised, organizations that we think should be really good and mature at rolling out enterprise projects, $500 million and up, aren't really doing that. And what happens is you cut down on things that the hospitals need the most, i.e. new CT scans, i.e. new gurneys, i.e. hiring new nurses to be able to help out. So if we do things better, I think before we get into the esoteric, machine learning and AI, just doing things better can actually save us a lot of money.
Well, one of the things that I've seen is a movement over the last 5+ years towards outcomes and accountability. And hospitals, particularly in the interventional cardiology and interventional radiology spaces that have gone towards more of that model in force ranking the surgeons, the facility, and the patient outcomes, have tended to do better over time because they're managing that continuum of patient care as opposed to the episodic event of a surgery at a given point in time. So I certainly see outcomes as playing or continuing to play a huge role in the management of that paradigm into helping control costs. And costs, again, not only at that one specific instance, but over the life of that patient from the time that they're followed up.
I would agree. Our company, we help provide solutions for companies to prevent errors from occurring, failures from occurring in processes, designs, et cetera. One of the panelists earlier talked about looking at things prospectively versus retrospectively to reduce costs in the healthcare system. And I think so many times we're looking at it after the fact and trying to figure out what went wrong. Where we come in is to help find what we can do right to prevent the failure outcome. So,
I'd like to say one more thing, which is the effect of over-regulation on our industry. Hospitals are finding that since 2010, 1 out of every $4 in revenue were used to fund administrative expenses. In 2016, that number was 1 out of every 3. And so what that means is the cost of regulation is, again, impacting the cost of healthcare. So if we can not only regulate for a larger cost of the insurance dollars, but also act together collectively to reduce the burden of regulation, it would have a significant impact on the level of care that we do receive.
Thank you, Minda. I think that leads right very well into our next question. In this era of government, when both sides refuse to work together for the greater good, how can you gain access and influence the House and the Senate to consider, write, and pass legislation to provide greater access to treatment for patients?
I've got some experience in this area. I've lobbied over the last 10 years with different medical device companies, specifically in the area of breast cancer reconstruction rights for women, and women having and understanding what their rights are going into it. Before the Women's Health Care Act of 1998, it was up to the insurance plans to determine whether that woman could seek reconstructive surgery. After that piece of legislation passed, every woman whose plan covers the mastectomy for cancer now has to cover reconstruction if she so chooses, which is an absolutely enormous benefit. I can't imagine a world where a woman doesn't have that choice. But in order to get that to happen, and the subsequent legislation that happened in 2016 on getting more education out to women, because still only about 30% of women in the country know this, is another issue entirely. We had to work not only at the society level with the plastic surgeons group and the breast cancer surgeons group, but then we had to influence the Senate Cancer Coalition. And of course, cancer is not partisan. It impacts everyone. So unfortunately, with the prevalency of that specific disease, everyone knows somebody that has unfortunately gone through that. So working with groups within the Beltway in DC, getting access to the individuals on those committees who then report up to the Senate Finance Committee, which governs HHS, which is the FDA, which is CMS, et cetera, is the way that we went about that. It's kind of like dripping water on a stone. But unless you know the pathway to go through in order to influence policy and create change and build support for an initiative like that, it's very tough to do on your own. So we had a lot of help, but over time, I think with the right momentum behind it, you can force change.
I'd like to add to that. Working with the government is rough, and I've found, and this is over 9 years, going back and forth, but you've got to get the government to buy into your ideas. And whatever those ideas look like, whether it's your congressmen, your senators, or if you can develop a relationship with whatever you're fighting, you've got to have enough documentation and backup for the fight, and it can take a very long time. But then one day you turn around and they're listening.
Yeah, I agree. Our constituency work started at the local level with our local representatives, which helped us open and gain access kind of at the federal level.
So I worked with California State Senator Hernandez 5 years ago to come up with a database wherein everyone that has been prescribed a prescription 2 should be captured. And after 5 years, we eventually passed what's called the Cures database. And that came about from, number one, a partnership. I was lucky to be the president of Southern California HIMSS, and we have 3,000 members in the healthcare IT space. And that carries gravitas going in the room if you're representing a body of people. However, that only gets you so far. You need to make your claims, your ask, personal. It needs to resonate not with the representative, but it needs to represent with the person behind the title. And when we start bringing up stories, and this was 5 years ago, the opioid crisis wasn't as it was now. So we had to bring real life stories. And what you find that, whether you're a Democrat or Republican, if you can get to that level and connect on a personal level, then you can kind of see how they would change a little bit. Now, don't get me wrong, when we were lobbying for this in DC, you still have to figure out, who to talk to first, and then who you can say, that, hey, this is being supported. At the time, it was Representative Ryan. And depending on who you're talking to, you have to bring up the right people with the right interests. But you need to make it personal. And what I've seen over the years is that a lot of lobbyists, they come in, you know, you're lucky if you get 10, 15 minutes. And in that 10 to 15 minutes, they try to cram so much data. They have a lot of, you know, the blue binders that they're pounding on the table. But what happens is they're just trying to get rid of you. You know, the worst thing that can happen when you're lobbying is what I call the nod of death, which is they're smiling and they're nodding. Once you get that, they're just looking at the clock. You need to make them either happy, angry, something, just not apathy. So to do that, you need to come at it from a personal level. So that's what I would do.
So my own experience is it seems to be just like any other thing you're selling, which is you have to show the politicians that you speak to what's in it for them first. And if you can show them right off the bat, here's the win for you, then they're more likely to listen to what you want after you've shown them that.
Very good point. Thank you for that. That was a very good point. Okay, next. Are there any financial risks involved using outside staffing companies for medical professionals and shortages with staff?
Wow.
I think that was teed up.
Yeah. I would actually, and this is not because I have a staffing company and everybody needs to use me, because that's never going to happen. It's never going to happen. But I would like to remind the industry that there's a couple different models of staffing, and pay very, very big attention to this, because I found something that's been with the government about 10 years now. So you've got your contingent models on your staffing for any hospitals and any practices that need outside assistance. Contingency is the dinosaur model. It's also the honest model, which means that anybody working for you, they're going to charge you when they do something, produce something. So I love the contingent model. I'm the contingent model. It means don't pay me until I've done the work. Then there's the other side of the industry. The other side of the industry are your retained staffing. And retained layers are your travel companies. They're your physician companies. And they do have different layers of laws to regulate. But we've had a nice little come in the middle type model that, you know, my hospitals personally know about, but we've had some bad contracts out in the industry, and people trying to pull, like, call a hospital, say you have an engagement fee. An engagement fee means, please, whatever hospital, give me $40,000, $50,000. When we place an employee, we'll go ahead and take that money back and everything's good. Only one problem. They take the hospital's money, they don't produce the services, they go on vacation for 6 months or a year. And I think it's sickening in my industry, and it's been a fight so we can remove this. So I just wanted to bring that up.
Well, I think, you know, to your question, Lynn, from my perspective, I think that there's more downside for not using external companies to fill these roles, companies that are ultra-focused on finding the right talent and placing them. If you're in the hospital system today, as Minda mentioned, with so many dollars going towards the administrative side and the progress prevention department, you know, you have very little focus on actually attending to the things that can drive your hospital's mission forward. And least of which is headcount, which is, you know, probably one of the most expensive items on the P&L. The more that they can delay those heads, the better their financials look for the quarter that they're in. So meanwhile, the quality of care goes down because you don't have the coverage that you need either in the surgical services unit or on the floor level in order to impact change.
So I started out as a trauma nurse and did work registry. So since I was making 50 cents more than everyone else. I was living the life, of course, and used to get the hardest patients in the ED that would come in because I was living the life at 50 cents more. Now, the reason I worked registry was because I wanted to learn from all of the hospitals faster, because the typical route is you stay in a hospital 5-10 years, and if you want, you can move on or move up. But I wanted to get a taste of how everyone did things differently. And one thing that I did not like about that experience is that you're looked at as a necessary evil, right? And the sad thing is, when people treat you that way, regardless of how you file your taxes, 1099 or W-2, at the end of the day, we're all trying to do the same thing, which is for the betterment of the patient. And now that I'm on the flip side, on the management side of hospitals, again, the worst thing that you can get out of an employee is not outrage. The worst thing you can get is apathy. And a lot of the mistakes that happen in healthcare is just when people don't care anymore. And it starts from the top down. If you treat contractors and extra folks as just like that, extra, and not integral in your system, then you start breeding apathy. And that's where not only costs go up, but lives get damaged in the process. So,
I think one of the most, the interesting thing that I've seen in the industry is a trend towards outsourcing technology and technology staff. One of the institutions that I work with, they technically fired their entire technology team and then outsourced them to an outsourcing company who then leased them back to the hospital. And for them, that created an opportunity, because what it gave them was the opportunity to ensure that the technology they received was the best, the most cutting edge, the most exciting, and they sort of eliminated the problem of having people who were used to doing things a certain way always doing them that way. They took them out of the equation, they took them out of the decision-making equation. And I can see that as being something that may happen more and more as the need to be cutting edge and on the cutting edge becomes more important to medical institutions.
My experience prior to the position I'm in now, I was vice president of a healthcare company. I'm a doctorate of pharmacy by profession, and we provided telepharmacy services, which was for rural areas, as well as after-hours services for pharmacists to be on staff, provide oversight into the hospitals that were still open 24 hours, and make sure that drug interactions were followed and, allergies, et cetera, before the medication could be dispensed to patients. So I think that's kind of going along with what you were saying. It's a little different than the typical staffing model, but I wanted to bring that to your attention as well, because that's a very up-and-coming and viable way of getting extra staff in certain areas, obviously not direct patient care, but for your support staff. So I wanted to bring that to the table as well. Did anybody have any other comments before we?
One other thing I would like to add is I think that healthcare is the industry is getting more sophisticated in such a way that they understand that you need to focus on your core competency. And for example, cybersecurity is not a core competency for the healthcare industry. So the more that we stick with what we know and ask people to help us in areas that are not our core strengths, the stronger we are. If you look at 10, 15 years ago, the model was to have everything homegrown, even the electronic medical records. That was a disaster. But now that we're maturing and we're understanding that, yes, healthcare is unique. However, there are people who know how to do this better than us with experience in other industries. So for my team, for example, I'll give you an example I'm doing right now. We're rolling out Clarity, which is a project management tool, throughout all of the UC system. And the consultant I got was the guy who rolled it out for Hyundai North America. And folks were like, why are you bringing in Vivek? I'm like, dude, he did it for 5 years.
Right.
over North America. Why would you want someone in the healthcare to do this for you when you have someone who's done it bigger, better, grander, and he can help us take care of the bugs? So we need to start thinking outside of our industry and understand that there are expertise out there and there's no need to reinvent the wheel.
We had that conversation at lunch, but you weren't there. Ian was stuck in traffic, so. But yes, thank you. That's a very good point. Because there are industries that are doing things that we definitely can utilize very well as a model to our success as well. Okay, I think we have time for another question, so I'm going to go on until I see somebody flagging us down. Till they tell us we're done. One more question, I'm being told. Okay, great. Thank you. What efforts can we do to get the right information to the right person at the right time and to make the right decision for the patient? I'm not handing it to you. You have to tell me.
Sure. From my standpoint, I think that integrated record keeping and making sure that the teams of specialists that are working with these patients all have access to the same information in a reasonable amount of time. With a personal example with my mother, who's just gone through her third thyroid cancer treatment, or surgery rather, it was amazingly difficult to get the radiation oncologist with the surgical oncologist, with the surgeon, and the other specialists involved to have access to the medical records so that they could see what has been done in a chronological order to make a good go-forward treatment decision for her and her health. And I'm sure that this situation isn't unique. I think it's pervasive. And I can't believe that in this day and age with the information explosion that's occurred, that this hasn't been sorted out. But I think it's far more common than not. And I think that improving that aspect of record sharing and being able to collaborate among specialists would make an enormous impact on the system. Ian, I'd be
Absolutely.
interested to hear what your thoughts are from
I
you.
know Ian has thoughts.
Yeah, so, yeah, I know, right? I've had the fortune of helping other countries with this problem. Finland is one, and right now Mexico. And what is interesting is that how I see it is we've put a lot of focus on making sure that the data is secure, which is a good thing in a way, but it also has diminishing returns. Because what happens is we put so much restriction on the data that the data doesn't turn into information, which eventually should turn into wisdom, right, for you to take care of the patients better. If you look at countries like Mexico, for example, HIPAA isn't a thing. They are sending information on WhatsApp. So that's probably on the other side of the spectrum where people, but the good thing about that is you can get a diagnosis, treatment plan, all of that within the same day. It is unthinkable even in the UC system. Now for Finland, for example, the nice thing with them is that they're actually, think about it as Google with a clinic. They start out with what are the technologies that we can put in to make data accessible, and then they start putting on regulation. For us, we started with regulation, and then bureaucracy, and then how do we make money off of this? Oh yeah, by the way, data, let's put that on top. So we need to reimagine things from the bottom up. Unfortunately, incremental changes in how we do things won't really solve it. We need to start reimagining. So I'm excited that you have folks like Google and Amazon really coming into this space, and had the opportunity actually to talk to Eric Schmidt, who was the CEO of Google in Vegas last year. Oh, here. And we had this long conversation about using AI to improve how we get data. And I told Eric, well, the problem we have is it's not that we don't have enough data. We actually have way more data than we need. The problem that we have is getting the right data at the right time. And people who have done, you guys, I told them, you at Google actually are really good at this. Because if I just Googled, red SUV, in a few minutes I get pop-ups from all the SUVs that are having sales, this, that, and the other. And I said, imagine if you're actually using your powers for good. If that is relevant information that we can use. And it's that kind of thinking that we need in healthcare, but we can't do it by incremental changes.
I think the elephant in the room is the EMR companies. When you look at the siloed systems that people have and the way they charge for their products, they don't allow open access to the data contained in the EMR. Even the patient who technically owns the data is not given the ability to remove their data from an EMR system and port that data someplace else. There are regulations that say they're required to do that. We have, and there is a format, FHIR, that the data is supposed to be put in so that it is portable, but the ability to execute on that is almost zero. And I think until we start truly requiring the EMR companies to open access to the data that's on their system so that patients can have access to it in a format that is understandable to human beings, then I don't think we'll be able to do that.
Thank you. So that was the end of our panel discussion. Does anybody have any questions from the audience for us? One question? Okay, she gets it. We have time for one question.
Hi, I wanted to know, how are personal benefit advisors affecting the market? I know there's companies such as Who Pays that are advocates, and they go in and negotiate pricing, discounts. They help the individual deal with claims and things of that nature. And I know a lot of companies are bringing them on to mitigate some of the HR work that gets forced on HR when an employee has an issue. Are you familiar with some of these companies as far as like the Who Pays?
I don't have any primary experience, so I'm kind of looking to see if...
So the answer to your question is they're having some effect on the patient side, but really they're just getting people what they're entitled to. They're not lowering the overall cost to the system, and they're not making it easier in general for people to get the benefits they're entitled to unless they have access to those specific services.
I think that's our time. Thank you.
Great job, guys. And of course, if you have any more questions for any of these fine folks, please make sure to see them during our cocktail hour.